Hello, let's talk about ischemic heart disease. What's ischemia? Well, it means that a tissue bed is hypoperfused. And I want that to be the one word that comes to mind whenever you hear the word ischemia is it is a hypoperfusion, meaning there's not enough blood getting to a target tissue, meaning that first and foremost, the oxygen demands of that tissue are not being met. But secondarily, that tissue, when it is metabolically active, produces some waste byproducts. And if there is no blood flow, then there is no mechanism through which blood cells can clear themselves of their own waste. And thirdly, supply themselves with the metabolites necessary to continue metabolic activity. So that's the basis of ischemia. And when you hear this word, it does not mean infarction. And namely, the big difference between ischemia and infarction is the degree of reversibility. And ischemia is a hypoperfusive event that is reversible, meaning cells have not died yet. But when you hear the word infarction, what you need to know is that it is a hypoperfusion in which cells die. So at the moment where cells start dying, it becomes known as an infarction, and it is no longer an ischemia. So those are the two big terms we had to get out of the way first. Ischemic heart disease is also known as coronary artery disease because any hypoperfusion of the tissue bed of the heart has to be directly due to a problem in the coronary arteries, which supply blood to the heart, because how else would there be a perfusion deficit? So the two terms are generally interchangeable. Ischemic heart disease is coronary artery disease, and ischemic heart disease is kind of the doctor variant, but your patients don't know what ischemia is unless they're very educated. And so you're going to be explaining IHD to them as CAD or coronary artery disease. So get used to using those two terms interchangeably. And what it kind of looks like, I've drawn a schematic right here on the right side of the page is, let's say you took a cross section of your left anterior descending artery. And in a healthy artery, there's no obstruction within the lumen. So flow can proceed as planned at all times. And then also the lumen can dilate and narrow however it wants to because there's no injury to it. But in coronary artery disease, you have atherosclerosis the majority of the time. And when you don't have atherosclerosis, then you have a normal sclerosis, typically caused by hypertension, or it could be caused due to the release of vasoconstricting elements, and that's called a vasospasm. So those are going to be the three mechanisms by which the lumen of your coronary arteries cannot dilate to a proper degree, and so you can't pass on an appropriate amount of flow to your myocardium. And what this means is that if you keep this up for long enough, this hypoperfusion, then the muscles of your heart are going to die because they will drown in their own metabolic waste. So we directly determine the degree to which coronary artery disease has progressed by looking at the diameter of the lumen on an echocardio, and the measurable amount of narrowing can be 75, can be 90%, and we'll see that that quantifies the degree to which this CAD has progressed. And to tie it all up to a very simple principle, we know that flow is the volume of fluid delivered through a tube per unit time. And so volume is based on area. And so if you decrease the cross-sectional area of a blood vessel, you decrease the flow that can fit through that vessel in any given arbitrary time span. So ischemic heart disease is exactly that. It is a deficit in the ability of your coronary arteries to perfuse your myocardium. Again, one more time, ischemia, we're thinking hypoperfusion, and it will turn to infarction, as we will see next, SDL, when your myocardium begins to die as a result of the hypoperfusion. So ischemic heart disease is a group of syndromes, which means it's a bunch of, it's basically, if you have this syndrome, you have a constellation of symptoms and clinical presentations that has a pattern to it. And so we'll see chest pain is going to present similarly every single time. And obviously things like exertion will cause that chest pain to present. And that's called a chronic stable angina. That's that pattern of pain of symptom presentation. And also with that chronic stable angina, well, there's no death of heart cells. There's no infarction involved, and so you don't see elevated biomarkers in that. But then when you start to get into the non-STEMIs and the STEMIs, which are going to be your myocardial infarctions, then you'll start to see different EKG changes as manifestations of these syndromes and things that differentiate between these different syndromes. You'll see EKG changes. You'll see that chest pain will start to appear at rest, and you'll start to see some biomarkers present with especially the acute MI, the ST elevated MI, and the biomarkers represent a transmural infarct, and we're going to get there. So ischemic heart disease is the most common type of heart disease in America. It's less common worldwide. I wonder why. The 4 major risk factors for CAD are hypertension, smoking, diabetes, and cholesterol. Oh, that's why it's higher in America. And I would dare say that age is one, and male gender before a certain point is probably one, but those are fairly obvious, and these 4 here represent modifiable risk factors, and therefore they will be the risk factors you're counseling your patients on and saying, hey, you need to do a better job of this, you need to do a great job of this, depending on the syndrome that they have. So how this is going to go is we'll talk about a lot of pathophysiology. We'll talk about the physiology behind delivery of blood to the myocardium. And then at the end of this, we'll get into these separate syndromes. So blood gets to the myocardium by means of the coronary arteries, and they penetrate from the outside of the heart inwards. And right now I want to establish the visual of your heart as your hand as the heart. So if you could imagine that your hand is pumping, 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 well then the inside of the heart is going to be your endocardium. And so that's going to be like the palm of your hand, right? And then the outside of your hand is going to be analogous to the outside of your heart. And then that's your epicardium. And so blood vessels penetrate your heart from the outside in, meaning if you're thinking about this analogy visually, well then they're moving from the back of your hand to the palm of your hand. That's the direction your coronary arteries are perfusing into your heart with. And so your subendocardial layer is going to be the first to die because in an event of hypoperfusion, that subendocardial tissue loses oxygen before the myocardium and before the epicardium. So because your heart is always beating 60 to 80 times a minute, every minute of your life, the oxygen extraction of your heart is near maximal. Even when you're sleeping, it's about 75% of its maximal oxygen extraction. And the reason for that is because it never gets a break. And so because it never gets a break and it's always extracting oxygen from your blood at a relatively maximal amount, the only way to give more oxygen to your heart is to increase blood flow. So you have to deliver blood extrinsically because you cannot upregulate the extraction of oxygen from within myocytes intrinsically. And that's a very important principle. And another important principle is flow reserve. And that's establishing the sense that you have a certain maximal capacity of blood that you can deliver to your heart at any time. You basically have a blood bank. And if your heart needs more blood, it will dip into its flow reserve in order to get funds from its blood bank. And it only has a certain amount of money in its flow bank, you know, and this money, the currency we're referring to, is vasodilation. So anytime your heart wants to buy flow in the event that it's exercising or you're sympathetically worked up, maybe you're really scared of something, your heart wants to buy flow, and it does so at the cost of vasodilation. And so as we get into the biochemistry of ischemic heart disease, we realize that there are certain things that make your coronary arteries shrink, and there are certain things that make them grow. And these are called vasoconstrictors and vasodilators. And if you want to have healthy blood vessels in your heart, you want to have a high degree of vasodilators ready to go at any time. And so looking into the text, those vasodilators specifically are going to be nitric oxide produced by endothelial cells in the larger coronary arteries. And then as you get into smaller capillary beds, adenosine is the vasodilator we use there, and it's released from cardiomyocytes during any event in which oxygen supply is inadequate. So that's really important because that means that adenosine is always being released by your cardiomyocytes. Every time you contract and relax, and contract and relax. Well, what we've represented at the top of this page is that every time you go into systole or you contract the muscles of your heart, well, this is what the lumen of your coronary arteries looks like. It's really narrow because your coronary arteries are going to be on the inside of that endocardium. They're going to perfuse down into that tissue to the point where any contraction in your heart muscle is going to compress and clamp those arteries almost as if you put a kink in a hose. So every time you contract your heart, every systole, that's what happens. And then during diastole, when your heart relaxes, then all of the blood flow that your heart needs per beat is delivered during that diastole. So because the oxygen demand of your myocardium is always changing in response to how hard it's beating, how much blood is going into it. Say thank you, Frank Starling. And your heart rate too, because all of these parameters are continuous, they're always being modified on a beat per beat basis. Well, then the amount of adenosine being released by your myocytes is also different on a beat per beat basis. So what that means is that your blood vessels need to be able to respond to adenosine and to lactate and to protons, which are also waste products of metabolism. They need to be able to respond to these vasodilating chemicals at the drop of a hat, within a second, within a fraction of a second. So any impairment in the ability of your endothelium to vasodilate in response to these different chemical vasodilators is the root cause of coronary artery disease. And so that endothelial damage is most often caused by, as we saw, atherosclerosis, and it so happens that all the risk factors we laid out on page 2, hypertension, smoking, diabetes, and elevated cholesterol, those are all risk factors for atherosclerosis. And in fact, atherosclerosis is involved in 80% of coronary artery disease because it is a direct mechanism for which the endothelium is damaged. Therefore, it cannot vasodilate in response to all of the chemicals released by myocytes whenever their oxygen demand goes up in response to exercise or stress. So the big thing to take out of the middle of this page is that adenosine is immediately attributable to myocytes and that nitric oxide is immediately attributable to endothelium. So if you get a question that says, well, what's the chemical that should be being released here? Or I'm sorry, rather, what's the chemical being released by these cells? Because that's a real simple first order question that they might throw a bunch of chemicals and see if you just freak out and choose the wrong one. It's going to be adenosine if they're referring to the muscles and nitric oxide if they're referring to the endothelium. Those are vasodilators. So the subendocardial layer is the most vulnerable to ischemia because, as we've stated already, it is the last to receive blood. And furthermore, every time you contract your heart in systole, the subendocardial layer is being compressed by that contraction. So that explains the progression of myocardial infarction from a non-STEMI to a STEMI. And what that means is ST elevation. And real quickly, getting into the EKG side of things, if you see ST depression during an episode of angina, what that means is that there's incomplete death of the wall of the heart, meaning that some of the heart is still alive in the area that's being damaged. And the reason that we know this is because anything that's depressed on an EKG is hyperpolarized, right? Because only positive signals and positive changes in membrane potential get registered as positive signals on an EKG strip. And so we know that if there's a hyperpolarization, well, only an alive cell is able to hyperpolarize. And so we know that there's injury there because these cells can't propagate in action potential nearly as much as they could when they were healthy. So the ST depression represents hyperpolarization, which is due to injury of tissue impeding the propagation of electrical current through the myocardium. And then ST elevation, as we would see in a STEMI, is one step farther, and an ST elevation represents a depolarization of that local region of the wall of the ventricular atria. And the elevation of the ST segment, representing a depolarization, reflects that all of the cells in that region of the heart have just been knocked off. There's no more left alive. And that's why we interpret the ST elevation as being indicative of a worse degree of MI than an ST depression. And that wraps up our talk about perfusion. Let's get into a couple of pages which discuss the mechanisms of myocardial ischemia. This is a rather dense section of the text, but I don't think there's anything too particularly intimidating within it. And I think that the test questions are fairly predictable. Atherosclerosis obviously is a mechanism of MI by means of the endothelial damage mediated by plaque accumulation and oxidized LDL. And atherosclerotic plaques tend to predominate within the first few centimeters of your coronary arteries, and you will not find much atherosclerosis as you get into the smaller and smaller microvasculature. Now, the degree to which one has atherosclerosis is somewhat coordinated with the degree of the anginal syndromes that person experiences. If they've got a 75% obstruction, they may begin to see this exertional angina or a chronic stable angina. But when that arterial or atherosclerosis progresses to about a 90% occlusion of any coronary artery, that 90% threshold tends to be when we see the unstable angina and the non-STEMIs start to come into picture, which means that your heart attack or your heart pain will begin manifesting itself at rest rather than simply with exertion. It becomes more unpredictable in nature, correlating with the degree of the stenosis. Looking at the metabolic and functional consequences of ischemia, this is a nice kind of flow chart, the cascade. It's rather intuitive, though I don't think you even have to look at it to be able to talk through it. The first and foremost, we're shifting over to anaerobic glycolysis whenever there is a hypoperfusion or an ischemia in the myocardial layer of the heart. That's very, 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 very big because we know that anaerobic glycolysis produces lactic acid, and we know that our myocardium is only going to shift over into anaerobic glycolysis when it is all out of oxygen with which to conduct beta oxidation and the citric acid cycle and oxidative reduction of all of those carbons that we pull off of fats. So when it's all out of oxygen, it shifts to anaerobic glycolysis, and that causes lactate to build up, and that causes acidity within myocytes and outside of myocytes, and this contributes even further to the damage done to these cells. But the acidity has a positive quality too, because we know that any acidic environment is going to right shift your hemoglobin association curve, and it's going to cause hemoglobin to drop off oxygen within that acidic tissue. And so that's our heart cells' mechanism of coping with the fact that they are hypoperfused. And if the hypoperfusion goes on for long enough, that's when the damage really accrues, and that's when you start to see some intracellular changes we'll discuss a bit later. I also wanted to highlight this phenomenon of stunned myocardium, which is essentially the heart stops beating, and then once it starts beating again, and this is applying only to a period of ischemia, not infarction, but a stunned myocardium means that you get this ischemia and it's reversible. And when it is reversed, those affected cells are still alive, but in the case of stunned myocardium, they have yet to resume their ability to perform contraction. And so you're going to see stunned myocardium in three settings, chiefly following a heart attack, following any open heart surgery, and following any stenting procedures. And again, typically this only applies to a section of the ventricles. So you're going to see it on 1 or 2 EKG leads, and it's not a global thing typically. But just be aware that this is a concept which is very common, especially for surgeons. And so it's kind of heavily tested because you have to be able to inference, oh, well, biomarkers aren't elevated. All the leads are normal except for that one lead. This person probably just has a stunned myocardium following an ischemic event and no infarction occurred. So a second or third order question that they can pull out of that is they can present to you a stunned myocardium and then say, what sort of histologic changes would you expect to see in this heart? And you would have to choose the answer choice that did not correspond to necrosis. And then we see that collateral circulation can develop if there is chronic hypoperfusion or ischemia within the coronary arteries. And the only presentation of collateral circulation, or rather I should say, the only question I can see coming out of this paragraph is that you could see an infarct in a question stem, And then they could say, well, that coronary artery did not have any atherosclerosis. And then they could say, what's going on? And you would have to know that, oh, okay, your RCA could grow collaterals in order to reach around to your left circumflex, and that's what caused the posterior left wall of the heart to infarct. The RCA plaque, even though that's not a region supplied by the RCA, or that's what would cause the right side of your heart to have an infarct. I probably messed that up a little bit just now, but you get the picture. And then moving on to an acute thrombosis, this is the #1 mechanism for acute MIs, and I've even seen this in a question. It was in Rowan's practice, where, not Rowan's, Robbins, where they give you an acute MI and then they just flat out ask you, what's the most likely cause of this person's MI? And the answer is a thrombus. It's not an atherosclerotic plaque, just in case you were wondering. Finally, a coronary artery vasospasm can be a mechanism for MI, and that's usually going to be due to the sporadic, spontaneous spike of local vasoconstrictors, such as histamine, serotonin, acetylcholine. This can be induced due to drug use. You can see a vasospasm due to cocaine that's popular in question stems. And what you need to know about this is that you're going to see so many vasoconstrictors absorbed by one section of the endothelium that part of the endothelium is just going to curl up and clamp in on itself, and it's going to take a long time to release that tension. And so when it is clamped up, whatever is downstream from that section of coronary artery is hypoperfused and thus ischemic. And then we get into an increase in myocardial oxygen demand. Obviously, the first thing we think of here is exercise. In the case of atherosclerosis, that's a real increase in demand. And right here in the middle of the text, it does mention 2 specific cases of anemia and carboxyhemoglobin, or carbon monoxide poisoning. And what I wanted to point out to you here was that both of these are going to present in some pretty non-traditional ways. And you're not really going to be thinking of these as root causes of heart attacks, because patients with anemia are going to present with some normal and some abnormal lab findings. They're going to have a normal arterial oxygen pressure, but an altered hematocrit. And so unless you get that hematocrit, you can't confirm or rule out an anemia. And then also with a carbon monoxide poisoning, you'll also see a normal arterial oxygen pressure there. And this is a problem diagnostically, because these patients have a hypoxemia, meaning they're not delivering enough oxygen to their tissues. And so because there's not enough oxygen in their blood, and there's not enough oxygen in their blood because all the hemoglobin is being occupied by carbon monoxide, which fits onto that porphyrin ring similarly to the diatomic oxygen molecule. And so these patients have a normal hematocrit. They have a normal oxygen pressure because there's nothing wrong with their lungs. Their lungs are fine, but they have this hypoxemia anyways. And this hypoxemia can induce a increased oxygen demand upon the heart. And if you can't meet that supply because you've already got some atherosclerosis, then the methemoglobinemia can be a direct cause of MI. Same with carboxyhemoglobinemia. And these will present with headache and dyspnea typically. They can be some real vague symptoms. And in the case of the dyshemoglobinemias, where there's something bound to that hemoglobin, you'll see the cherry red, hands and toes, fingers, characteristic of the carbon monoxide poisoning. And so something I want to bring up is that that's also going to be a left shift on the hemoglobin saturation curve, the oxygen binding curve, and anything that's going to cause a major shift in that curve, left or right, is going to acutely and abruptly change the oxygen demand of the heart one way or another, which could sort of be a shock to the blood vessels. So let's get into our anginal syndromes. What is angina? Angina is chest pain. And how does the pain get there? Well, it starts because, well, let's go back one step and think about it. The pain's there because you have nerves that go into your heart. So what are the nerves that go into your heart? Well, the vagus nerve goes into your heart, and then you have some sympathetic nerves that go into your heart too. And either of those, the afferent branches of either of those, can be activated and lead to the sensation of pain when their activity is communicated to the neocortex. And the way that that message even gets started on the endings, the free endings of the vagus and your sympathetic cardiac nerves is through tissue ischemia, which is going to cause the release of adenosine, protons, etc., by all of your myocardial cells. And the accumulation of these metabolites within the extracellular fluid eventually diffuses their way on over to free endings of nerve cells and chemoreceptors, and it activates those nerve cells and sends an action potential through those neurons, and that's what immediately goes to different pain centers. So in the case that a patient has neck and jaw pain, that's going to be referred pain from your vagus nerve, because that's going to go to your nucleus of your solitary tract and then refer down to your jaw and your neck. And then in the case that you have a shoulder pain, well, that's going to be your cardiosympathetics going to the sympathetic chain, sympathetic ganglion, and overlapping with your sympathetic innervation from the kind of T1 to like T4 area of the heart, or of the trunk, which corresponds to the front shoulder, you know. And then if you have an epigastric pain, my best crack at that is that that's going to be vagal efferent activity, efferent with an E, I should say, that just continues to go on down to the stomach, because you know that the vagus nerve lies atop the heart and then it continues going down. So that's the mechanism for how you get chest pain. And this chest pain is going to present in different scenarios with different remittent patterns to it. And if the pain goes away with rest, that's called a chronic stable angina pectoris. And this is called exertional angina because you don't get the pain at rest. It's only there when you're working out. And so these patients will be hiking, or they'll be in a really aroused moment. It could be a patient having sex. That's a common question stem. It could be a patient that has to spend a lot of time outside in the cold and they really don't like that. And side note, a cold exposure left shifts your hemoglobin oxygen retention curve. So there's this extreme stimulus and they start to get chest pain. And then when they sit down to rest, it goes away and they're cool. Or when you give them nitroglycerin, when they take that sublingual, they're also cool. So your chronic stable angina is going to be due to atherosclerosis 9.9 times out of 10. And it's not due to clotting. I want you to make that differentiation right now. You see chronic stable angina described in a stem. Well, then the reason for it is because of a plaque occluding the lumen of a coronary artery leading to hypoperfusion. And we'll see later if it's immediately due to a plaque. Well, then that question could say, here's a patient with unstable angina. What's the mechanism for their chest pain? You know, and the answer to that is it's going to be a blood clot, but it's a plaque for stable. It's a blood clot for unstable. That's how that aspect of things may be tested. Getting back into the pathophys of it, the chest pain directly results from ischemia because, again, there's this hypoperfusion or failure to deliver blood to the muscle of your heart, and that causes this muscle to spit out adenosine and lactate and protons, and all of these things irritate nerves. And then when those nerves get irritated, they send an action potential back up to a specific area of your spinal cord and then your thalamus and then your cortex that lets you know, oh, hey, something is not right in this area of my body. And because there is some circuit overlap within your nervous system, that's why the pain gets referred. And so the myocardial ischemia, again, at the metabolic level, causes an increased oxygen demand. And we know that the three things that factor into oxygen demand are going to be heart rate and stroke volume and wall stress. And we know that, well, in the presence of a hypoperfusion, those cells have to work harder. And so I would say that the contractility is what's really being affected by hypoperfusion there. And remember, stroke volume and contractility are basically the same thing. And so they're having to contract harder, or they're having to spend more energy to contract with the same amount. That's leading to the increased oxygen demand. And going back to the concept of flow reserve, as we've talked about, it's kind of an economic thing. You know, anytime your heart works, you have to be able to buy the blood flow that you need, because you cannot upregulate oxygen extraction intrinsically. And so you have to buy it from an outside source. And the currency you use to buy this extra flow is diameter, specifically the diameter of your coronary arteries. So when your coronary arteries can't spend any more diameter, but they need to, we call that coronary artery disease because you've hit your flow reserve. And we see that this inability to raise your flow any higher because you can't spin any more diameter on it is mediated by endothelial dysfunction. We've talked lots about that already. It goes hand in hand with expression of VCAM on the surface of this endothelium, which is going to get macrophages in there, which is going to activate those macrophages and amplify inflammatory signals, which kind of irritates the endothelium and might cause them to reveal subendothelial patches of collagen, which is where a clot can start to come into the picture. Later, we're talking about fixed threshold and variable threshold angina. Those are really obvious. Just read it once and think about it, and you know what those are. And then finally, the last thing that we talk about with a chronic stable angina is that with exertional angina, chronic stable angina, we've got ST segment depression, and that reflects that there is a hypoperfusion, meaning that some cells have been knocked off, but then other cells are perfectly fine, and the ST segment depression is associated with hyperpolarization on EKG. So what sort of biomarkers would you expect to see floating around in the blood with someone with chronic stable angina and ST segment depression? And the answer to that is you're going to see normal biomarkers because they haven't had a heart attack, because you're still in the period of reversible cell injury. It's a hypoperfusion, but it's not enough to cause infarction or death of these cardiomyocytes. And then what layer of the heart would you expect the ischemia to be most prominent in? And the answer to that is, well, it's ST segment depression. It's got to be subendothelial. Anytime you see ST segment depression, you're thinking subendothelium and only subendothelium. Because if it's depressed and not elevated, you know that some of the heart is still functional. And then using that knowledge, you know that the subendothelium is always the first to get bombed. So let's go on to Prinzmetal angina, which is the most rare type of angina. So rare, it's termed variant angina. And I would summarize this in one sentence by saying it's postmenopausal women who smoke tend to get vasospasms, and that vasospasm causes an ischemia leading to angina. So it's a vasospasm, a spontaneous constriction, and the most prone culprit that we know of thus far is thromboxane A2, which is released by platelets. And this chemical is derived from arachidonic acid, and it's a signaling molecule that tells the lumen of any blood vessel to constrict. And so when it does that in your coronary arteries, you get a hypoperfusion of your myocardium, and the subendothelial layer is the first to go. But with a Prinzmetal angina, you don't see ST depression. Remember, we said ST depression means subendothelial ischemia, but an ST elevation means it's going to be a transmural ischemia. That means the whole wall is affected, from the epicardium to the myocardium to the endocardium. But what makes Prinzmetal angina a non-acute coronary syndrome is that the cells don't die. The vasospasm is short-lived enough to where it'll relax eventually, and then all of the downstream cells that weren't getting enough oxygen, well, they'll get reperfused. And so they'll be hurt, and during that hypoperfused state, you will see ST segment elevation, but then when blood returns to all of the cells of your heart, then the ST segment will go back down to normal. They'll be isoelectric once more, and those cells will not have died. And Prinzmetal angina is characterized by pain that occurs at rest, so that differentiates it from chronic stable angina, which we know does not occur at rest. And then Prinzmetal tends to pop up in the early hours of the morning. It can particularly wake a patient from their sleep. And once more, there is a strong correlation with females who smoke. And the way that we test for it is that we inject a bunch of vasoconstrictors into their coronary arteries, and we put a stopwatch on it, and we look for how long it stays constricted. And if it stays constricted for like a 95th percentile time, you know, something that we have measured across multiple people, then we're going to be able to diagnose it's Prinzmetal, because this is clearly a vasospasmic disorder, not an atherosclerosis, which we're also going to look for that too. Then we're moving on to cardiac syndrome X, which I would best describe as tends to be women who get this chest pain, but then you take an echo of their heart or an angiogram and their arteries are normal. They do not have a high degree of atherosclerosis. And so you're sitting there looking at them like, well, how do you have this chest pain? And the answer is cardiac syndrome X, which we believe is due to vasospasms, which, as we just talked about, is due to local vasoconstricting metabolites. But in the case of syndrome X, we really have not established what metabolites cause it, what sort of a hereditary component is there to it. All that we know is that it's an autoregulation problem of the microvasculature, so the really small vessels that immediately perfuse your subendothelial and your myocardial layers. Syndrome X may not respond to sublingual nitroglycerin, may see ST segment depression. I don't think that this image here is particularly important to know. And I think that syndrome X is going to be fairly obvious should you see it on an exam. So I've highlighted the things that I think you ought to know. Now, moving on to acute coronary syndromes. This is the last component of this SDL. And acute coronary syndromes are the difference between an acute and a non-acute coronary syndrome is that ischemia progresses to infarction, right? And so reversible cell damage progresses to irreversible cell damage. And that's where you start to see an MI come in, is once cells have infarcted, there is no saving them. And another difference is that acute coronary syndromes tend to present with a drastic chest pain that gets worse, either worse over the duration of one episode or worse over the course of several episodes intermittently spaced. And a third thing that ties together acute coronary syndromes is that they tend to be due to a plaque rupture and the formation of a thrombus. And so that's stated here at the bottom of page 10. The immediate cause of acute coronary syndromes is the disruption of atherosclerotic plaque, and that's highlighted in the middle of this chart here, and it causes what's called a mural thrombus, which is a blood clot arising from the wall of an artery. And that clot is really bad news, because if you think you were hypoperfused back here, you know, when you had a 50% luminal occlusion with this plaque, well then what about now with this thrombus, when all of a sudden, number one, you're all of a sudden at like a 90% occlusion of this lumen. And then number two, that thrombus, man, that thing's not steady. That could break off at any time. So not only are you hypoperfused, you're at risk for that clot breaking off and occluding a microvessel and knocking off myocytes for good permanently. So that's what separates, again, acute coronary syndromes from something like a chronic stable angina or a Prinzmetal angina or a coronary syndrome X, is the development of this thrombus. So let's take a look at unstable angina. This is in contrast to stable angina. What makes it different? Well, number one, it occurs with rest, or it occurs at rest. You can just be sitting in your chair, you know, and all of a sudden your heart starts hurting. Well, if you're a doctor and you hear that, you're like, okay, you're past the stable angina phase, you're already into the unstable angina phase. And number two, it gets worse over time, like we said. And it's also called a pre-infarction angina, because if you see a patient with unstable angina, you better not tell them to walk up any stairs. You better tell them, always take the elevator, have everybody chauffeur you everywhere. You know, if they're in your hospital, get them a wheelchair, wheel them to the food court and back, because you do not want these people having an elevated heart rate or an elevated stroke volume, because buddy, you're going to be taking them straight into the OR if they do, and you're going to be putting a cabbage in to get that artery bypassed after a clot occludes 99% of the lumen. So an unstable angina occurs at rest and gets worse over time. It's an easy diagnosis to make, really, and I think that the stable, unstable, and Prinzmetals, those three kind of get lumped together, and it's really easy to tell them apart. And same thing with the syndrome X. You know, making a diagnosis for these coronary syndromes is not going to be the challenge on this test. It's going to be understanding the physiology behind the development of the symptoms that you see. So an unstable angina, how is it classified? Well, nowadays we kind of lump unstable angina in with this thing called a non-STEMI, which is
non-ST elevated myocardial infarction, which means that some cells have died, but it's not a transmural infarct. Because if it were a transmural infarct, we would see ST segment elevation. So a non-STEMI or a non-ST elevated myocardial infarction is basically unstable angina plus cell necrosis, cell death, infarction. And what that means is that unstable angina is physiologically the same thing as a non-STEMI, except you don't get that cell death or that infarction at the end of the line. So you will not see any biomarkers such as CKMB or troponin I that are associated with infarction. And one more time, I want to take a commercial break and say that ischemia is hypoperfusion without cell death. It's reversible. And infarction is hypoperfusion with cell death. There's no coming back from it. You get an infarction, hello macrophages, hello neutrophils, because you're going to start clearing that debris out and laying down scar collagen to compensate for the fact that you no longer have a wall of your heart, you know. So that's ischemia versus infarction. Getting back into unstable angina, the pathogenesis of an unstable angina, as we've said, is always a thrombus, always a thrombus, always a thrombus. And yes, the thrombus has to form on top of something, and that something is usually going to be an atherosclerotic plaque. But on a test, if a patient has unstable angina, you're going to choose thrombus, because if it were just a plaque, well, then you're thinking stable angina. You know, you're thinking this patient has chest pain with rest, but because nothing's being dislodged and nothing's floating downstream to block up a lumen, it's not an unstable, it's not a non-STEMI, it's not a STEMI, right? So thrombus, unstable angina, and it's an incomplete occlusion, not a complete occlusion. That would be a STEMI. I would like to talk now about the development of a thrombus. So a thrombus is best explained by, I would say, this flow chart once you know what it is, but really when you're looking at it, it's here on this right side. It's a blood clot on the wall of a blood vessel. And how does it get there? Well, these things called platelets are going to bind like Elmer's glue to any exposed collagen. So what's a platelet? We know that platelets are these pinched off bags of cytoplasm, and they come from these cells called megakaryocytes, which live in your bone marrow. And these megakaryocytes, their only role in life is just to pull off these little bags of cytoplasm from themselves and throw it into the bloodstream. And that's a platelet. And so a platelet has within it all of these enzymes made by a megakaryocyte. And all of these enzymes that a platelet has within it serve one purpose: to get it to stick to other platelets and to encourage inflammation in a blood vessel, because platelets are your clotting mechanism. But what you ought to understand right here, right now, right off the bat, is that platelets are only half of your clotting mechanism, because this is your clotting cascade, right? And so this is a bunch of stuff that helps platelets stick together. We know that a fibrin solidifies a clot, but this is not the entire picture, because you have a total other side of the coin here that is dedicated to not clotting, or what's the word for that? Anticoagulation. You have an anticoagulative system that is constantly flying around to cut apart different clotting factors and to inhibit platelets. So going into this discussion, remember that you do have a system in place to prevent you from clotting too much. So platelets are the clot side of the system, and they're made in megakaryocytes, and they're released and they float around the bloodstream, and they are looking for collagen to bind to. And they are very picky, because they can't bind to the top of an endothelial cell just anywhere, because that endothelial cell does not express collagen. So they need to encounter a region of damaged endothelium to be able to bind to collagen. And really, they don't bind to collagen. They bind to this thing called von Willebrand factor. And von Willebrand factor kind of acts as an adapter to stick a platelet onto some exposed collagen. So you have this von Willebrand factor, and platelets will stick onto it. And once they're stuck, these platelets that are just little bags of cytoplasm, they degranulate. So what cell type have we ever seen before that also degranulates? Mast cells. So mast cells, they bind to their IgE that's presented to them by a B cell in the case of recognition of an allergic antigen, and these mast cells just go crazy, and everything that's in them, they just out into the extracellular space. And I want you to understand that platelets do the same thing. Same exact thing. They are analogous to the mast cell, except the stimulus for the platelet is von Willebrand factor. So VWF is acting towards the platelet as IgE does to the mast cell. And when these platelets degranulate and pop open, all of the enzymes that were made by the megakaryocyte get released into the bloodstream, along with ADP. And ADP, adenosine diphosphate, is a signal to recruit other platelets to also degranulate and compile and multiply and amplify this entire platelet activation cascade. And so one of the other enzymes or components of platelets is vasoconstrictors, and it's specifically thromboxane A2 and thromboxane synthase, which is the enzyme that creates TXA2 from free arachidonic acid, is exclusive to platelets. Platelets are the only thing in your body that have this enzyme kicking at a high level. So thromboxane synthase, what does that do? Well, it's a vasoconstrictor. So if there's damage to your endothelium, the evolutionary mechanism that your body has for healing this damage is number one, to vasoconstrict so that it doesn't get any worse. And then number two, to clot over top of it, and then remodel that clot over a longer period of time into something a little bit flatter. Moving on down, it is mentioned in the text, platelets degranulate and release vasoconstrictors. That's not good. Platelets also have this GP2B3A receptor. This is a drug target for patients who have experienced MI, because what do we want for those patients? We certainly don't want clotting. So we give them antiplatelet drugs. And one of those is the GP2B3A inhibitors, and another category is heparin, fractionated heparin. These things will stop a new clot from forming. And so that's the anticoagulant aspect of things that I referred to earlier. We want to encourage anticoagulation within these patients who are experiencing anginal symptoms so that it doesn't get any worse. And then finally, you have fibrinogen binding to these platelets, specifically binding to GP2B3A. And this fibrinogen gets activated to fibrin by thrombin, and that's shown down here in this chart or flow chart, and that's what cross-links platelets and really sets that clot in place. So for right now, the big takeaway is that you need exposed tissue factor and exposed collagen on some subendothelial tissue in order to initiate the clotting cascade. You need to know that this cascade is a bunch of proteases that cut each other up and modify these proteins into usable forms. And where have we seen this before? The complement cascade. So the same sequence is happening here for many of the same reasons. And so you know the gist of this. It's going to be proteins that cut up other proteins, and it's going to terminate in the formation of fibrin on a platelet meshwork. Moving back into the symptomatology of unstable angina, here it is at the top of page 13. Unstable angina occurs at rest and increasingly grows worse. The pain grows worse over time. This is a reminder that a non-STEMI, meaning ST segments not elevated, is basically unstable angina to the point of infarction. It's got biomarkers, so you're going to see your CKMB and TNI. So let's get into sudden cardiac death. It typically occurs as a consequence, and so a consequence of MI. So MIs can be non-fatal, and MIs can even be asymptomatic. You know, you might have a heart attack and not even know that you just had a myocardial infarction. And because we're defining an infarction as a death of myocardium, you know, well, if it's a very small region, then you don't know what happens. And so how does the myocardium die? Hypoperfusion. So what are the names that we give to these syndromes of hypoperfusion? Well, it's either stable or unstable angina, right? And both of those hypoperfusion syndromes can sort of evolve into a heart attack if a big clot develops inside the lumen of a coronary artery. So that's how you get from the syndrome to the heart attack. But when you have the heart attack, just because you survive it doesn't mean you're out of the blue, because one of the most common consequences of a heart attack is an arrhythmia, and we'll see that in the very next SDL. Arrhythmias occur in something like, as a consequence of something like 90% of all heart attacks. So if you have a patient who just drops dead out of nowhere in a question stem and they never went to the ER to get treatment for their chest pain, you can assume that it was a subthreshold MI and that the cause of death was an arrhythmia secondary to the tissue necrosis in that region of infarction that flew under the radar. I think that this is a fairly common line of questioning, or at least let me rephrase that. If I were asking a question, I would give you a sudden cardiac death question just to see if you knew that the arrhythmia was the consequence of having a subthreshold MI. So that's what it's due to. You have an MI, you don't know you have an MI, and then during the remodeling phase, arrhythmia. Why is it there in the first place? Atherosclerosis. That's all I got for sudden cardiac death. Just know that you're going to see a patient in a stem who drops dead out of nowhere, and maybe you could get some histology out of it, as we'll see the next lecture is very histo-heavy. Or maybe they could pull the what's the reason for this question, and that would be, well, they had a non-STEMI and they didn't realize they had it and their heart was remodeling. So chronic ischemic heart disease, not much to talk about here. It's this progressive congestive heart failure as a consequence of ischemic myocardial damage. And man, that is a dry sentence, but that's exactly what it is. There's nothing that makes this really distinct from anything we've talked about so far, other than it doesn't, it's CIHD if you haven't really had a bad heart attack yet. Let me rephrase that. You've got heart failure without MIs, basically. And then it's going to present as a cardiomyopathy with a mitral regurgitation. But it's not due to MIs, because it's not due to infarction. It's due to ischemia. So if you remember this concept of a hypoperfusive ischemic stroke, remember vascular dementia. That's it. Remember that we talked about vascular dementia as this type of dementia that could add up over and over and over across several very small sub-threshold little ischemic events, right? And remember that if you just hypoperfuse the brain again and again and again and again, well, then eventually brain cells get lost. And that concept, when you apply it to the heart, that's chronic ischemic heart disease. So I'm sorry that I can't explain it any better than that, but we have already encountered this exact pathology in a different organ system. And then finally, we're getting into infarction, myocardial infarction. We got a whole SDL coming up on that. And you need to know one more time that an infarction is an ischemic event that gets pushed to the point of cell death. So it's irreversible. You're not bringing those cells back. And what's happening inside the cell to differentiate an infarction from an ischemic event is that you see the increase in intracellular calcium, because a cell that's just hanging on can sequester calcium inside of its ER, inside of its mitochondria, and keep that calcium out of the cytoplasm. Because calcium, when it gets inside of the cytosol, just flies around and interacts with lots of different proteases and turns them all on, and it's a signal for autolytic activity, and you don't want that. So the release of calcium from mitochondrial stores is signal numero uno that a cell is dying. It's basically dead at that point. There's no going back once the calcium comes out. And so then you start to see these fragmenting and dissipating nuclear changes. And this is called pycnosis or karyolysis or karyarexis when it's fragmenting. And this is an irreversible condensation of chromatin. So we know that heart cells can't divide anyways. And so once the pycnosis starts to develop histologically, you know they're done for. And along with this, partially mediated by the calcium, partially mediated by some free radicals, partially mediated by a lot of proteases, you start to see membrane damage because there are phospholipases, again, calcium activated, that start cutting up all these different membrane fatty acids, and your mitochondria has a membrane too. So when you start to see membrane damage, that is a sign that the cell is dead. It is irreversible. And at the level of the tissue, that is going to appear grossly as elevated CKMB and elevated TNI. So that's a preview of what we're about to talk about in the second SDL for ischemic heart disease. Thank you for sticking with me up to this point. I know that this is particularly dense material, so please have a dialogue with me if you are unsure of any of these mechanisms biochemically or presentations clinically for these patients, and we'll talk through it and reach an answer together. Over and out.